Hey everybody, Evan and Irma here with another fascinating discussion in the world of health tech and digital health. Today with a real innovator and industry insider, physician entrepreneur, Dr. Lyle. How are you?
Hey, I'm doing great.
Good to see you. Thanks so much for joining. Where your expertise is really incredible, and we have so many questions about the future of healthcare and virtual care, digital health,
Mhm.
telemedicine, as we sometimes call it in particular. Before all of that, maybe you could do some quick introductions to us, to the audience, a little bit about your biography and background and the great work you do.
Sure. So my name's Lyle Berkowitz. I am an engineer who became a doctor, who became a executive and entrepreneur, and have always been a bit of a tech head. So I did biomedical engineering, but I always knew I wanted to go to med school and focused on primary care is my calling, but always blended it with this field of what's called medical informatics, the application of IT and computers into healthcare. And so started my career at Northwestern Medicine here in Chicago, practicing part-time and being the medical director of technology for my primary care group back in the mid 90s, where that basically meant getting people access to the internet, but started exploring electronic medical records early in my career, and wound up helping to implement those EMRs into our primary care group relatively early on, the early 2000s. So had some experience with that. Along the way, I also wound up getting involved in a variety of digital health companies as an advisor, chief medical officer, sort of part-time executive. And eventually at Northwestern, got very involved with being an executive in our group, initially IT, but eventually in the innovation side. Eventually had an executive role across the whole health system, and started not just advising companies, but actually founding some companies with partners, and over time becoming more involved in that. And eventually, all these things came to a head, and I left Northwestern to join one of the big telehealth companies, a national telehealth company, where I oversaw operations product strategy, helped us scale up, and then left there to focus on another company I'd started years before called HealthFinch, which is in the automation space. Sold that and wound up starting this new company, KeyCare, which is in the virtual care space. So I've gone from sort of being mainly a doctor to going back to some of my engineering roots in terms of problem solving, but I've always sort of combined this love of tech with my love of medicine, with starting new things into some type of career where I get to change jobs on a regular basis.
Well, this is truly a fascinating background. I don't think I've ever met somebody who started as an engineer and moved into medicine. Myself was engineering background and problem solving kind of approach to everything. I think we need so much of problem solving and innovative approaches in medicine and healthcare. So thank goodness for you being there. And now that you're in the virtual care space, I wonder if maybe we can start with telehealth myths. Maybe you want to address or dispel some of them for our audience?
Yeah. So there are a couple of big myths, right? Pre-COVID, telehealth was looked at as maybe a lesser part of healthcare or something that some other third parties did. It wasn't done very commonly by health systems. And even that's a myth. The truth is, the very first phone call Alexander Graham Bell made was a virtual telehealth visit. He called his assistant, Dr. Watson, said, Dr. Watson, come here, I hurt myself. We have been using virtual modalities in healthcare forever, the phone being the most obvious. The problem has always been, well, who pays for them, and does it make sense in a world where you're not getting paid for it? And what happened in COVID turned that around. So all of a sudden we could bill for telehealth. Before COVID, doctors at health systems could not really bill much for telehealth. A couple third-party companies, including one I worked for, had established these individual payer relationships. And so it was getting to be a couple million a year of telehealth visits. But now it's exploded. It is easily 10% of all healthcare. is done via telehealth, in some places even more. And that's in part because it's getting paid for, and in part because patients really like it. And it doesn't mean every patient likes it for every time, but a good chunk of patients love the convenience of virtual care, particularly for what we'll call routine issues, things where they don't, it's not super complex. They just need someone to talk to, whether it's their doctor or a partner. And they just want to make sure that's done in a coordinated manner. So yeah, I think myth number one is that telehealth is brand new. It's been around for a long term. Myth number two is that telehealth is dying, that it was only a COVID thing. I think COVID was the proverbial genie out of the bottle. But the truth is it went from under 1% of all healthcare. Yeah, it went to 80% at one point, but it's settled in the 10 to 15% easily. And some would argue that should be closer to 25 to 50% of all healthcare could be done online in some virtual capacity, as long as we figured out the right payment mechanisms. And in fact, if we do it right and we make it more efficient, it may solve this doctor shortage issue, not because there are more doctors online, it's the same number of doctors, but if we can do things online more efficiently over time, it actually could solve a lot of those issues that we face.
Really important insight there. And yet we're in the midst of this sort of telehealth apocalypse, at least with private companies. Explain what's happening there for the folks who might not be inside the industry. And you talk about something called isolated telehealth. What does that mean as far as where we are and the challenges and limitations we're seeing today?
In the past month, right, we've seen a combination of some of the big telehealth vendors start to stumble. Teladoc fires their CEO. Amwell has been struggling. Its stock is, a penny stock. We saw Optum pull out of telehealth services. We saw Walmart pull out of both its physical facilities as well as its telehealth services. So some people would say, oh my gosh, telehealth is dead. It's over. That's not the case at all. What's happening is, I'd say, the age of the isolated telehealth vendor is coming to an end. This concept of just going out there, putting up a shingle, going direct to consumer and expecting them to come to you just doesn't make sense anymore. It's an isolated experience, which means the experience is distant from where you get the majority of your healthcare. And that's a problem because you have to register into some new system. And second, they don't know who you are. The quality may be affected because they don't have all of your history, and the history is not being shared back with your doctor. And the third thing is that financially, it's hard to get aligned. If you're not part of a mothership, then the primary care and the stuff you can do as telehealth doesn't necessarily have the same financial oomph as if you're doing it as part of a more holistic area. And so I'd say the new era that we're going to see is what we'll call the coordinated virtual care partner that can offer care in a hybrid approach, meaning you can do online care that's coordinated with a office-based system. And if you do that, you get better experience, particularly if the technologies are matched. You get better quality because the data is shared. And there's more financial alignment because you're taking care of the patient holistically rather than in a isolated silo.
This is very interesting, this approach of the isolated telehealth and now moving into the integrated or coordinated telehealth. So you pretty much kind of laid out the benefits of it already. Can you talk about maybe barriers to adoption of that approach as well? Are there regulatory barriers? How is the reimbursement working? Obviously, we know that's been cut back post-COVID. So expand more on this vision of coordinated telehealth.
So the majority of telehealth these days, and healthcare in general, is done through health systems. So even though there are some interesting third parties out there, that people still go to their health systems for majority of their care. And they can do scheduled telehealth visits with their doctors. There's on-demand urgent care type visits. The biggest problem, people will say, oh, patients want to come back in the office. Study after study has shown that's not the case. When you ask patients, they'll say they really like telehealth. In fact, usually, and we've done studies, others have done studies, about a third of patients say they prefer doing online care, particularly for routine issues. It's more convenient, easier, fits into their lifestyle. It makes sense. Everything else they do is digital. About a third will say, I prefer to go in the office. That's okay. Some people still want to go in the office. It's that white glove treatment they want. And a third will say, whichever can get me in easiest, which is probably going to be virtual care. And so if the demand is there, what's going on? Well, if the numbers are down, that means the supply is the problem. And that's because doctors in offices, they are officeologists. They're used to being in the office. They are optimized from both a operational and financial perspective for working in the office. Everything's set up for them. For them to do some office visits and a virtual visit, there's a cognitive dissonance. I mean, think about that. It would be like, Evan, going from personal interviews to video interviews back and forth. And there's a flow that you get during the day. And remember, most visits, it would be, Evan, imagine, or Irma, if you had to do, 4 of these interviews an hour for 7 hours a day, you'd want it to be as consistent as possible. So doctors are used to being in the office. They're officeologists, and we don't pay them as well to do virtual care in many cases. And/or recent studies showed that they're less efficient when they're switching back and forth. Meanwhile, we're seeing the rise of what we'll call the virtualists, doctors who are actually optimized for virtual care. That's who our group is building up, this panel of virtualists who are better and more efficient at doing this. And they're used to doing quicker care for more routine type of things. And financially, it makes sense for a health system. A health system would much rather see a smaller number of highly complex patients, because they know in the population health pyramid, the upper 5% of patients represent 50% of all the cost and most of the profit in health system. The reason they have primary care doctors is it's all a big funnel, top of the funnel, to find and take care of patients so that the ones who need more complex care come in the health system. And that's what the health system's good at doing, and that's great. So for the health system, though, to spend a lot of money on routine care doesn't make sense. So the health system wants you to come in the office and wants you to focus on anything that makes the doctor more efficient in the office. And the doctors, they would like them to do more virtual care, but the doctors just aren't incentivized to do it. Furthermore, they're not incentivized to endorse team-based care. So part of what I'm doing with my virtual care group is saying, let's be a team to the office-based doctors. Imagine if your doctor had a team of 2, 3, 4 other doctors and nurses to help take care of patients. Well, they're not going to use that team if they're not going to get in any way financially improvement because of that. So if they aren't getting paid in some way, they're not just going to let someone else see their patients. Incentives really matter here. And so the issue is never the technology here. It is about how we align our physicians, how we compensate our physicians, maybe the single most important thing that a health system can do to embrace and improve the use of virtual care and team-based care so they can improve access to the system.
Wow, intriguing opportunity. Let's talk about a related topic that many people think is key to unlocking, value and innovation in healthcare is data, specifically data sharing and the importance of breaking down silos and helping patients and providers with data, their data, managing it. What are you doing there to kind of facilitate data sharing and across disciplines and providers and patients to doctors and doctors to doctors? It's such a challenge. What say you?
Yes, well, it's interesting. So back in the early 2000s, the government came out with what they called meaningful use programs, and that was a lot of money to pay doctors to increase the use of electronic medical records. And they figured that the way to best promote this would be to pay doctors to use an EMR and have some type of outcomes and show that they could keep a medical record online, etc. But what they didn't do, looking back, what they probably should have done was say, and we want you all to work on a common data model. As a result, what happened is you've got hundreds of these electronic medical record EMR companies with different data models, and none of them speak together perfectly. There's some similarities. You can trade some basic info, but the bottom line is they all have different data models, and most of them site to site can't even speak to each other. We use Epic because, one, it's the most prolific EMR out there. 60+% of health systems are using Epic as their EMR. Two, they've got a common data model, and they have created technology that allows sharing between any site. So if you go to hospital A, if I'm a doctor at Northwestern, and you, Irma, are usually seen at UCLA or Mayo Clinic or some little hospital that uses Epic anywhere, and you see me at Northwestern, I will have access to all of your records. That's called Care Everywhere. So we took advantage of that when I built up a virtual care group. We use Epic also so we can communicate with so many other health systems. And that data sharing becomes important. So when I see a patient, when my doctors see a patient for a virtual visit, they've never seen them before, but we have access to their records. And the result is that we can take better care of the patient. We know who they are. And when we're done, all of our records go immediately back to the primary care doctor and health system that sent the patient to us, so that bidirectional sharing of data becomes really important from both an experience and a quality perspective. And if you think about it, it allows for better overall research and better overall care. And so that to us was really, really important. And we're fortunate that there is sort of a common operating system that so many people now are using, single EMR, but it took 20 years to get there.
Great point.
Want to go back to the basics? I see you have your doctor's bag right there in the background. So obviously, the vast majority of people get into healthcare because they want to help patients and they want to, take care of them. So you've talked a little bit about that broken experience from the health system perspective and the physician perspective. So now, as a patient advocate, patient myself, I wanted to talk more about the patient experience and patient perspective and patient engagement. I love this idea of care everywhere. I love the idea of having all my records available to whoever I'm seeing. So how can telehealth providers, those vendors and those third-party organizations, how can they increase patient engagement, how they can work with health systems to get integrated more? And then how can we increase trust? And for patients to know that their data will be shared. And how can the seamless experience be created that will benefit everyone?
Yeah. Well, it's what we've set up is a bit different. And whereas because we are working on Epic, we can seamlessly interact with all the other health systems on Epic. The result is patients do have a seamless experience. They can go into their health system and still access the virtual care doctors we provide. So we help health systems expand capacity, et cetera. And we're bringing on urgent care, primary care, specialty care, et cetera. For other third-party, these isolated telehealth vendors, they're struggling right now to figure out how do they fit into this system. So I think it's going to be very interesting to see how this plays out, because both health systems, but also payers and employers are looking for more of this hybrid approach. And I think we're going to see health systems expanding the type of telehealth they offer. And I think we'll see more companies trying to align. We partner with some companies to help them work with us to fulfill some of these. So we tech enable our doctors with additional technology, but we also sometimes doctor enable technology, service enable technology. So there's some interesting tech out there that we can start using and then basically providing as a service to health systems, so that all this data is connected. I mean, it was a bet that we took a couple of years ago when we went on this direction. I think we're seeing it play out. I'm a health system guy. I grew up in health systems. Health systems are extremely important. We all need health systems. We can't just replace health systems with online care. But health systems can extend online care. Health systems are not known for super easy, convenient online care. And so you, Irma, when you have a mild problem, and you can't get through your health system, you'll go and find whoever you can. Part of my job is to try and help health systems provide the same level of convenient care that a patient like you could find anywhere. Because I really believe strongly that there needs to be that type of coordination, and that I want my health system focusing on the really big stuff, curing cancer and heart disease and broken bones and really complex medical patients. I don't need my health system being, is not going to treat a cold any better, but I want them to be able to offer me a way to treat a cold really easily. And that's where I think partnerships come into play.
Fantastic. I feel better already knowing that maybe this will be coming to a health system near me where
I'll ask you this, Irma. One of my fundamental theories, and this is going to be hard for health systems, right, is that there's a certain amount of care in that bottom part of the pyramid. I call it the triple R threat that overwhelms our doctors. Routine, repeatable, rules-based care. And that is the basic care that once you're stable, you might have hypertension, diabetes, but you're stable. How do you feel about your doctor saying, hey, Irma, you're doing well. You don't need to see me, 4 times a year, maybe once a year, maybe every other year. My online team's going to handle you, and you only need to come in if there's a new problem going on. And, the issue is, how are you going to feel about that? How will doctors are going to need to be incentivized to do that? You're going to need to feel comfortable that it's good, consistent care. But if it's routine care, how well do you think others will feel about, I'm happy to see someone online, as long as I know if something major happens, I can get in. And that's what we're trying to balance and bring scalability to care. And we look at that bag, you go, why does a virtual care doctor have a bag? I used to go out and visit patients, and that's wonderful. That's how it used to be, but that's not scalable. And and so we made offices. You come to the offices. In the 1990s, we came up with hospitalists because I couldn't go to the hospital every morning and spend time with patients and be in the office. And now virtualists are just simply another extension of the doctor. And everyone has their place. And so I'll be curious, you talk to a lot of folks, how well people will accept and adopt that philosophy.
Well, first of all, with telehealth, we're getting this other dimension that has been lost to the medicine, where the physician can see patient in their own environment, if it's virtually, but they can kind of get a peek as to what that environment is. Maybe the patients will be able to kind of share what are the barriers to care, why they're not making progress, etc. So I think that element of it should not be forgotten, that you're kind of you're visiting the patient again in their home.
That's great. I jokingly do say sometimes we're bringing the house call back, aren't we?
Yeah. And then, house calls, obviously not scalable, but so important sometimes. But now to answer your question, I would look at what you've offered in terms of seeing somebody else for routine care. I would see a tremendous benefit if I was unable to be followed up more than once every 3 or 4 months, especially for chronic condition management. What if we can start bringing in additional data to see how am I doing, not at these 3 or 4 points during the year when I come into the office and measure my blood pressure. Maybe I can do this at home. I can check in, and we can have more of a continuous management of chronic conditions. I see that as a great benefit to patients. So if we explain it that way, if we position it that way, especially knowing everything is integrated on the back end, and your physician is going to be involved if something changes, if more interventions are required, then I see that's to be great.
This concept of remote patient monitoring, right? And continuous monitoring of some sort, is becoming important. A single doctor in the office, we can't handle that. No. But this is where, when I talk about virtual care, I'm talking about, of course, telehealth, real-time visits, but there's also asynchronous messaging, and there's also automation, like having a automated tool following your blood pressure, glucose, etc., and only escalating if there's a problem or if you're not doing it. And so you're right. The future should ideally be a more continuous, rather than you see me once or twice a year in the office, in which case, I've got 15 minutes and a point of time with you only.
Makes sense. Let's talk a little bit about the business side at Key Care. this partnering with health systems. How's that going? What are the challenges? What are the opportunities over time? Maybe you can just touch on what you can as a private company, of course.
Yeah. So when you start a company, and I've been fortunate to start a few, you want to have what's called product market fit, meaning do people pay for what you have? And we've been very fortunate. On one hand, I've sold tech to health systems in the past. I vowed never do that again. God bless them. I love health systems, but they are hard to bring new technology in. This what I'm doing now is different because we're selling access to a service, right? We're not making them use new technology. And in general, the typical health system sales cycle takes a long time, can take 1 or 2 years. We've done a really good job with product market fit. In a year and a half, we have already signed 16 health systems representing over 100 hospitals and 44,000 physicians and millions of patients. We have 10 more in contract and many very large ones. So we've really shown we've got this fit that health systems are saying, hey, we have access issues. We have workforce shortages. We are not specialists in virtual care. We would love for you to come and help supplement what we're doing. We're not taking everything over. They're still doing virtual care on their system, but we are simply acknowledging that they have access issues and let's help with that. So we've done that. And that's been really thrilling. We started with 24/7, 50-state urgent care. And that's a great way to start. But we also believe there's a lot of room to expand in primary care, behavioral health, and specialty areas that we're starting to roll out and just starting our journey. So we've done very well, Evan, in what we call the land phase. We've landed a lot of health systems. We've started work. Now we're in the expand phase. How do we expand the type of things that we can do with them, taking care of more and more of their patients so that those patients feel really connected and taken care of by their health systems.
Yeah, I'm sure that's a testament to you solving a need that healthcare systems are facing with physician burnout. We have a primary care crisis. We now have mental health crisis in terms of number of patients that need care without the number of providers increasing the same way. So having that hybrid approach is certainly addressing those problems. So I want to turn to future trends. What emerging trends you see in telehealth, but maybe beyond that, and just digital health in general and healthcare overall? Would love to get your take.
Yeah, well, I'll tell you, in terms of how we're going to spread, one of the big things we certainly acknowledge is we have to say, hey, we're not this extra thing that you pay for on the side. We really need to be covered by insurance. And so what we've done is we've started partnering with the health systems to have them do some of the billing. We're also looking at getting separate contracts. And so the more that we're looked at as just yet another group that insurance covers, the better, just because that is the nature of how people accept healthcare. Second is, we're clearly seeing the use of AI in every aspect of healthcare. We're taking advantage of it. Epic is rolling out. They just rolled out what they call summary generalization, using AI to summarize a past history of a patient. So when we see a patient, we could ideally have a summary of this patient as a 50-year-old with this medical history and has had this many sinus infections. Be super helpful to make our life and our physicians' experience better. We're looking at a variety of ambient AI vendors. These are the vendors that use AI to listen to a doctor taking a history and basically summarize that into a written note, which is fantastic for efficiency. And then we've got a couple of other things that our innovation team is working on to just make the overall experience as automated, efficient, and effective as possible. One of the benefits of doing virtual care is that by default, we've got patients who are using some type of phone or computer system who will be able to go on ahead of time and do certain things. Whereas if they come in the office, you may have them have a piece of paper to fill out, et cetera. Everything we do is online, and we can really take advantage of that. And I think that is, it's the nature of how we're of how every part of health, of not just healthcare, but every part of our society is going digital. And we have the advantage of sort of forcing it to see us needs to be more digital. And we believe that will, in the end, support both efficiency and effectiveness of care. And not only a better outcome, but a more financially viable and scalable outcome.
Wonderful sentiment. Well, it's been a delight to hear your journey and the insights and the opportunities. Um, Spring here in Boston, as it is Chicago. It's been a long winter. What are you looking forward to over the next weeks, months, personally, professionally? What any meetings or travel coming up, Doctor?
I feel like I'm happy. I don't have any travel coming up. The past 3 months, there's been a conference at least every other week or so. I love getting out there, talking to people, seeing people. This is a fascinating environment. Every day, I love doing startups. It's fun. It's new. It's challenging. But most importantly, what I love is thinking that we're trying to help the health system transform. We're not simply looking to shift people to doing visits online, but how do we bring all of tech into it? Again, virtual care really enables us to be more technology forward in many cases. And that's what I think we need. Our healthcare system is broken, but I don't believe we have a shortage of physicians as much as we have a shortage of using them efficiently. So when we are thinking about how to improve things, it's not simply taking a 15-minute office visit and making it a 15-minute video visit. We're really thinking dynamically about how do we more efficiently take care of, particularly that triple R, routine, repeatable, rules-based care, that big block of care. How do we outsource that online and do it as efficiently as possible? Because if we do that, we relieve the pressure on the doctors, we expand the capacity of health systems, we still ensure everyone's getting the right care and there's plenty of money to go around. And maybe we're taking the burden off the ERs for inappropriate care, but that's a good thing. And overall, our health system right now is not working great. I always say I have job security because we have not fixed the health system. And that's our big goal. And that's what gets me up every day, Evan, is thinking, how do we make the health system better by combining technology with amazing doctors online and improving the amount of care that we can deliver in an efficient way.
This is fantastic. This is systems forward thinking. It's an engineering based problem solving. And I think that's what we really need in healthcare, for sure.
I appreciate it. Yeah. A lot of these, as a doctorpreneur, I find a lot of my fellow doctors who go into this and field tech and entrepreneur, there are a lot more engineers out there than you might believe, Irma. But you're right. This is a big, fascinating, complex game theory engineering problem. And so, like I said, job security and constantly stimulating as to how we can continue to fix what is the technology sometimes is easy. It's the financial alignment and the change management that sometimes is the harder part. But it all, I believe, is solvable.
Oh, fantastic.
On that very optimistic note, we really appreciate you and what you do and your time and interest in sharing with our audience. And thanks, everyone, for watching. Reach out to Dr. Berkowitz and Key Care on LinkedIn, Twitter, YouTube, all the channels. And we look forward to following your journey, Doctor. Thanks so much.
Appreciate it.
Thanks, Dr. Berkowitz. Okay. All the best.
Thanks.
Bye.
Bye-bye.